Very warm welcome to everyone listening this session. Today our topic of discussion is Middle East Respiratory Syndrome coronavirus. Essentials of diagnosis: mild, moderate or severe respiratory illness. Travel to endemic area including Saudi Arabia, United Arab Emirates, Qatar and Jordan within 14 days before symptom onset. Contact with camels reported in many cases. Fever, cough and dyspnea. CDC can assist with real-time PCR. Middle East respiratory syndrome mortality is 36 to 45% and treatment is supportive. General consideration: Middle East Respiratory Syndrome is a syndrome associated with a coronavirus similar to the cause of SARS. Patients with MERS have had a history of residence or travel in the Middle East, in particular Saudi Arabia, or contact with such patients. The virus is transmitted between humans through direct or indirect contact of droplets. The virus is shed in stool, but the role of fecal-oral transmission is unknown. The earliest cases were identified in 2012 in the Kingdom of Saudi Arabia, and 75% of all cases have occurred there. Additional cases have occurred throughout the Middle East, Africa, and Europe, with a reported death rate of 36%. So-called super spreaders are often responsible for propagating the pathogen in early stages of an outbreak. It is also recognized more often that asymptomatic cases are frequent, especially among children, and they may contribute to disease transmission. Person-to-person transmission can occur within families. Hospital-associated cases comprise 10 to 25% of cases. The median incubation period is 5 days, with the mean age of 50 years and 65% occurring among men. Over 90% of patients have an underlying medical condition, including diabetes, hypertension, or chronic heart or kidney disease. Those with diabetes, kidney disease, chronic lung disease, or other immunocompromising conditions likely are at highest risk for severe disease. Camels, especially the female camels, appear to be the principal reservoir, and several studies show that contact with dromedary herds of camels is greater among cases than controls. Raw milk ingestion. The camel milk ingestion is considered a potential source. Persons who work with camels are more likely to have antibody evidence of past infection. Signs and symptoms, with the most common symptom being fever, cough and dyspnea. Chills and rigors are common. GI symptoms may occur, with diarrhea being most common, followed by nausea and abdominal pain, and may precede respiratory symptoms. Mild and asymptomatic cases are reported. Hematological findings in the largest series to date include thrombocytopenia, lymphopenia 34%, and lymphocytosis 11%, with derangement of LFTs, and chest radiographs are nearly universal and include increased bronchovascular markings, patchy infiltrates or consolidations, interstitial changes, opacities, both reticular and nodular, and pleural effusions, and total lung opacification. The findings mimic those of many other causes of pneumonia. Serum serologies and real-time PCR are available through CDC. Highest viral loads are found in lower respiratory tract specimens, including bronchoalveolar lavage fluid, sputum, and tracheal aspirates. These samples are preferred for diagnosis. So these are the symptoms and signs of Middle East respiratory virus, the COVID MERS. Complications include respiratory failure, and 89% of patients they went for mechanical ventilation, and the patient mortality is high in COVID associated Middle East Respiratory Virus Syndrome as compared to the SARS Middle East Respiratory variant. So, treatment is mostly supportive. The use of macrolides is not associated with the reduction of mortality. Ribavirin, interferon, they are given for at least 14 days. The overall mortality is between 36 to 48%. Now, these are the complications and preventive measures to be taken. Travelers to Saudi Arabia, they should practice frequent hand washing and avoid contact with those who have respiratory symptoms. Because healthcare workers engaged in procedures that involve contact with respiratory droplets are at risk, isolation of high risk patients is essential, as are simple hygienic measures. Public health authorities should be reported, and surveillance is essential. Post-exposure prophylaxis with ribavirin and lopinavir/ritonavir for healthcare workers is associated with a 40% decrease in the risk of acquiring infection. The camel workers, including slaughterhouse and market workers, veterinarians, racing personnel, should wear facial protection and protective clothing and practice good personal hygiene. Family members of such personnel should not be exposed to work paraphernalia, including clothing and shoes, and workers should shower at the site of employment rather than the home. Avoidance of direct contact with camels, the milk, their urine and feces, they should be avoided, and infected camels should be segregated from other livestock. Current vaccine candidates include subunits to the receptor binding domain, whole DNA, viral vectors. These are under study, and soon we'll consider that they will be developed. The vaccination for Middle East Respiratory Syndrome. So this is the important points regarding this important disease. Thank you very much.